Welcome to another episode from the Veterinary Research Channel. Today we're diving into the fascinating world of veterinary surgery, specifically focusing on a common issue in our canine companions, cranial cruciate ligament disease.
That's right, and we're looking at a recent clinical research paper from the Veterinary Surgery Journal titled, A Mismatch of Planning and Achieved Tibial Plateau Angle in Cranial Closing Wedge Surgery. An in silico and clinical evaluation of 100 cases by Charlotte Banks, Gareth Michael Coor-Jones, and Richard Lawrence Meeson. It's a deep dive into a specific surgical technique.
Instability in the stifle joint, which is essentially the dog's knee.
And surgical treatment is generally recommended to manage it. There are several techniques, but many of the proximal tibial osteotomy procedures, like cranial closing wedge osteotomy and tibial plateau leveling osteotomy, share a common goal: to reduce the tibial plateau angle.
The tibial plateau angle is the slope of the top surface of the tibia, the shin bone. The aim is often to reduce this angle to around 5 degrees. Why 5 degrees? Because biomechanical studies have shown that reducing the tibial plateau angle to between 4 and 6 degrees is sufficient to dynamically stabilize the stifle joint that is deficient in the cranial cruciate ligament by eliminating cranial tibial thrust.
Good point. The cranial closing wedge osteotomy procedure was first described assuming that the angle of the bone wedge removed would simply be the difference between the preoperative tibial plateau angle and the target 5 degrees.
However, there's a challenge with this original method. When the bone wedge is removed and the pieces are brought together, the tibial eminences, which are proximal landmarks used for measurement, shift cranially. This causes what's called a tibial long axis shift. To try and overcome these challenges, modified planning methods have been developed with adjusted wedge angle calculations. One popular method was described by Oxley and colleagues.
Their modified cranial closing wedge osteotomy technique used an isosceles wedge, meaning the two cuts forming the wedge were of equal length. This wedge was positioned more proximally along the tibial tuberosity. Another key feature was maintaining a caudal hinge of cortical bone to help with alignment and stability during surgery.
In the Oxley method, the size of the wedge needed varied based on the preoperative tibial plateau angle, with wedge angles calculated differently for grouped ranges of increasing preoperative tibial plateau angle. For example, if the preoperative angle was 20 degrees or less, the wedge angle was preoperative tibial plateau angle minus 5 degrees, but if it was between 31 and 35 degrees, it was preoperative tibial plateau angle minus 2 degrees.
The location of the ostectomy, meaning how far down from the patellar tendon insertion, was determined by body weight, with a more distal ostectomy recommended for larger dogs over 25 kilograms. This was done to allow for enough proximal bone stock for implant placement.
In a previous study using this modified method, the median postoperative tibial plateau angle was reported as 6.5 degrees, which is close to the 5-degree target, but not exactly 5 degrees. That study focused on dogs over 20 kilograms, but the method is also used for small dogs.
So, this new study set out to investigate the Oxley modified cranial closing wedge osteotomy method. They had 3 main goals. First, to see if the method actually results in a 5-degree tibial plateau angle when planned virtually, which they call in silico.
Second, they wanted to compare that virtual planned angle to the actual angle achieved in clinical cases that were performed according to the Oxley guidelines.
And third, they aimed to determine what impact performing the ostectomy further down the bone or distalizing it had on the virtually planned tibial plateau angle.
They had some hypotheses going into this. They hypothesized that the virtually planned tibial plateau angle would hit the target 5 degrees. They also hypothesized that there would be no difference between the virtually planned angle and the actual postoperative angle.
And finally, they hypothesized that performing a more distal ostectomy would lead to a greater tibial long axis shift and therefore result in an undercorrection of the resulting tibial plateau angle.
Now let's look at what they found in their results section. The study included 100 stifle radiographs from 90 dogs. 84 of these dogs were small, weighing 25 kilograms or less, and 16 were large, weighing over 25 kilograms. The median weight was 13.1 kilograms, with a range from 4.1 to 44.7 kilograms.
The mean preoperative tibial plateau angle across all dogs was 28.6 degrees. Interestingly, the mean preoperative angle was higher in small dogs, at 29.3 degrees, compared to large dogs at 25.3 degrees. This difference was statistically significant.
When they performed the modified cranial closing wedge osteotomy virtually, the mean post-planning tibial plateau angle for all cases was 7.6 degrees. There was no significant difference in the post-planning angle between small and large dogs. So, right away the post-planning angle was higher than the 5-degree target in both groups.
They also checked if an appropriately sized bone plate could be virtually placed, and they found that it was considered appropriate in all cases after the virtual procedure.
Looking at the actual clinical cases, the median overall postoperative tibial plateau angle was 5.5 degrees. The median angle in small dogs was 7 degrees, while in large dogs it was 4.5 degrees. The median postoperative angle was higher than the 5-degree target in small dogs only.
They measured the position of the ostectomy in the clinical cases and found the median position was 8.6 millimeters from the patellar tendon insertion. The position was more distal in large dogs at 12.6 millimeters compared to small dogs at 8.3 millimeters. The median ostectomy position was more distal than the recommended 5 millimeters for small dogs and more distal than the recommended 10 millimeters for large dogs.
Comparing the virtually planned angles to the actual postoperative angles, the study found no statistically significant difference overall.
The study also looked at how the results varied based on preoperative tibial plateau angle categories, following the ranges from the Oxley paper. For the virtual cases, the mean post-planning tibial plateau angle didn't differ significantly between the different preoperative angle categories. However, there was a trend where the amount of undercorrection, meaning how far above 5 degrees the planned angle was, increased as the preoperative tibial plateau angle decreased. The only group where the planned angle didn't statistically differ from the 5-degree target was the group with preoperative angles over 35 degrees, where the planned angle was 6.4 degrees.
In the clinically executed cases, they saw an inverse trend. As the preoperative tibial plateau angle increased, there was a progressive undercorrection. The postoperative angles did differ significantly between the preoperative angle categories. Specifically, the postoperative angles in cases with preoperative angles between 21 and 25 degrees differed from those with angles over 35 degrees. Cases with preoperative angles between 26 and 30 degrees, and those over 35 degrees, had postoperative angles that were statistically different from the target 5 degrees.
The third part of the study evaluated the effect of performing the ostectomy at different distances from the patellar tendon insertion in the virtual planning. They tested distances of 5, 7.5, 10, and 15 millimeters.
The mean post-planning tibial plateau angle was different depending on the ostectomy position. The angle didn't differ significantly between the 5 and 7.5 millimeter positions. However, the angle was higher at the increased distances of 10 and 15 millimeters.
This demonstrated a progressive undercorrection of the planned tibial plateau angle as the ostectomy was moved further distally. The planned angle was closest to the 5-degree target when the ostectomy was at 5 or 7.5 millimeters. However, the mean planned angle for all tested distances was greater than 5 degrees.
Now let's move on to the discussion, where the authors interpret these findings.
The authors evaluated the planning method described by Oxley and colleagues and the resulting tibial plateau angle, comparing virtual planning to clinical cases. They found that when executed virtually, the Oxley wedge angle calculations did account for increasing preoperative tibial plateau angle, but they did not achieve the intended 5-degree target in most groups, only coming closest in the group with excessive preoperative angles over 35 degrees.
So their first hypothesis, that the virtually planned angle would achieve 5 degrees, was rejected. They suggest that if achieving 5 degrees is indeed crucial for eliminating cranial tibial thrust, then the current Oxley guidelines for calculating the wedge angle should be modified.
Although the virtual planning consistently reduced the tibial plateau angle to a range of 6.4 to 8.4 degrees regardless of the preoperative angle, the postoperative angles from the actual clinical cases differed. This means their second hypothesis, that there would be no difference between the virtually planned and postoperative angles, was also rejected.
This discrepancy suggests that either the surgical planning in clinical cases or the actual execution during surgery differed from the Oxley recommendations in the study's cases. The study observed that the surgical correction to the 5-degree target was better in dogs with lower preoperative tibial plateau angles and least effective in cases with excessive preoperative angles over 35 degrees.
A significant finding was that the position of the ostectomy in the clinical cases was often more distal than the recommended positions for both small and large dogs. The author's virtual experiment confirmed that distalizing the ostectomy resulted in a progressive undercorrection of the tibial plateau angle regardless of the preoperative angle. This supports previous evidence that the impact of tibial long-axis shift is greater when the ostectomy is performed more distally.
There are several possible reasons for the difference between the virtually planned outcomes and the actual postoperative outcomes. One possibility is that during surgery, decisions might be made to place the ostectomy more distally to ensure there's enough room for implant placement.
However, the virtual planning in this study showed that the appropriately sized plate could be placed properly even when the ostectomy was performed just 5 millimeters from the patellar tendon insertion. Performing the ostectomy at 5 and 7.5 millimeters virtually resulted in the planned tibial plateau angle closest to 5 degrees. The The fact that the planned angle didn't significantly differ between these two positions suggests there might be some flexibility for plate positioning during surgery.
Despite this, identifying the exact location using things like hypodermic needles during surgery can be less precise than in virtual planning due to soft tissues, potentially leading surgeons to err on the side of a more distal osteotomy to be safe. But going beyond 7.5 millimeters might reduce the amount of correction achieved.
Another factor could be that the clinical cases in this study were planned using different software that didn't allow for virtual osteotomy and prediction of the resulting tibial plateau angle beforehand. This lack of detailed pre-surgical simulation might have influenced how closely the actual surgery matched an ideal plan.
Also, precisely executing the planned wedge size and shape during surgery can be challenging. It's hard to know retrospectively how accurately the measured distance for the wedge base was achieved, and the thickness of the saw blade used to cut the bone can also contribute to discrepancies.
The Oxley modified cranial closing wedge method is commonly used for small dogs, but the original Oxley study didn't include dogs under 20 kilograms or those with excessive preoperative tibial plateau angles over 35 degrees. This study specifically created an additional category for these excessive angle cases and calculated the wedge angle the same way as the 31 to 35 degree group, by subtracting 2 degrees from the preoperative angle.
The study's results showed no significant difference in the virtually planned or actual postoperative tibial plateau angle between small and large dogs. This supports applying the method to small dogs and those with excessive preoperative angles, although modifications might still be needed to consistently hit the 5-degree target.
Cranial closing wedge osteotomy might be preferred over tibial plateau leveling osteotomy in dogs with excessive preoperative tibial plateau angles because rotating the bone too much in tibial plateau leveling can risk fracturing the tibial tuberosity. However, studies on complications after tibial plateau leveling haven't consistently shown an increase in this fracture for dogs with excessive angles. Some have even described combining both techniques for excessive angles, although that has been associated with a high major complication rate.
Potential drawbacks of cranial closing wedge osteotomy include limb shortening and potentially causing the patellar tendon to sit lower, known as patellar baja, or leading to patellar tendinitis or hyperextension of the stifle joint. Using the Oxley method, removing a proportionally large wedge, especially for excessive preoperative angles, might make these effects more pronounced.
Other modified cranial closing wedge osteotomy techniques have been described to try and address these issues. For example, one described a 25-degree neutral wedge that aimed to correct the angle while removing a smaller wedge, potentially reducing limb shortening. Another described a juxtaarticular approach, closer to the joint, to maximize bone contact and reduce the effect of tibial long-axis shift, reporting consistent correction close to the target. Yet another method based on the anatomical mechanical axis aims to correct caudal bowing of the proximal tibia often seen in affected dogs. Interestingly, recent studies suggest that patellar baja and tendinitis after modified cranial closing wedge osteotomy might be more theoretical and haven't been commonly demonstrated.
This specific study did not evaluate the clinical outcome of the cases included. While procedures generally aim for a 4 to 6 degree postoperative tibial plateau angle, previous research has shown good clinical outcomes even with higher angles, sometimes up to 14 degrees. More research is needed to connect the final tibial plateau angle after the Oxley method to clinical outcomes, particularly in cases with excessive preoperative angles where higher complications have been reported in other studies.
The authors noted that a small number of cases in their study ended up with a negative postoperative tibial plateau angle. This wasn't seen in the virtual planning, suggesting inaccuracies during surgery. A negative angle converts cranial tibial thrust into caudal tibial thrust, putting strain on the caudal cruciate ligament, which stabilizes the stifle during weight bearing. Since caudal cruciate ligament tears are common in stifles with cranial cruciate ligament disease, excessive leveling that results in a negative angle could cause injury to that ligament. The clinical significance of a negative tibial plateau angle is unclear but is considered unlikely to benefit joint stabilization.
Finally, like any study using radiographs, the positioning of the limb and the presence of osteoarthritis might affect the accuracy of measurements. The authors tried to minimize this by including only diagnostic quality, straight radiographs. While osteoarthritis is common, it's been shown to have minimal impact on measurement repeatability.
The measurements were performed by a single experienced observer, which helps minimize variation between measurements. Previous studies have shown variability between different observers measuring tibial plateau angle, so using one observer helps maintain consistency within the study.
In conclusion, the authors state that the modified cranial closing wedge osteotomy, described by Oxley and colleagues, needs modifications to consistently achieve the planned 5-degree tibial plateau angle target. The study did show that this method results in a consistent reduction in tibial plateau angle for cases with excessive preoperative angles.
Clinical cases often differed from the surgical plans, although sometimes the actual outcome was closer to the target than the plan predicted. Importantly, their findings suggest that distalizing the osteotomy is not necessary to allow for appropriate implant fit according to the planning.
And distalizing the osteotomy should be avoided if possible, because it worsens the tibial long axis shift and leads to potential undercorrection of the final tibial plateau angle.
More research is definitely needed to figure out the actual clinical impact of this undercorrection and whether the Oxley planning method should be specifically adjusted to consistently hit that 5-degree target.
It's clear that while modified cranial closing wedge osteotomy is a valuable technique, achieving that ideal 5-degree tibial plateau angle consistently requires careful planning and precise execution, and potentially further refinement of the planning guidelines.
Absolutely. A great deep dive into the complexities of this common surgical procedure. That brings us to the end of this episode. Thank you for listening to the Veterinary Research Channel. A link for the reference paper is in the video description. Remember to test your knowledge by answering the questions in the description, and as always, keep those minds inspired, hearts light, and tails wagging.